So now we're going to, over the second half of the meeting, we're going to have a bit of a panel discussion. We've got a series of questions that are going to dig into some of the key issues that have been highlighted in these three presentations. During that time, please do make use of the Q&A function in Zoom to pose your questions. If we don't have time to get to some of those questions, and we'll try and do that, but if we don't, what we're planning to do is take all the questions from this afternoon's webinar and this morning's webinar and do a frequently asked questions kind of document that will be shared with you or all people who register for the meeting, along with links to the papers and links to the webinar recording as well. So we will endeavour to answer the questions either today or in the next day or so. So without further ado, I'd like to ask Monicah to open our discussion for us. And the question I'd like to ask you about, Monicah, is given the persistent backlog in cataract in many countries, with the perspective of your leadership role within the Ministry of Health in Kenya, which of the health system innovations do you think are currently proving to be most effective at scaling up cataract surgical services?
Yeah, thank you. Thank you very much, Matthew, for that question. And I'd just like to also thank the presenters who talked before me. And I think that's a very important question. And when we're looking at this, it's important to approach it from the demand side and the supply side, while also ensuring that we are giving comprehensive services, or we are using a comprehensive approach, not just looking at surgery in isolation, but the entire process, and ensuring that services are patient or people-centered. And first, I want to tackle it from the community side. So what strategies do we have to ensure that we are creating demand and that services are accessible? So number one of the biggest barriers from the community level is cost. Cost is a key barrier that hinders people from accessing cataract surgical services. So strategies that ensure that the cost barrier is addressed, such as health insurance, social health insurance, to reduce out-of-pocket expenditure is really, really important. And while this also addresses the cost barrier, it also ensures that services are somehow sustainable. We also need to look at physical access, because in our settings, we'll find that physical access, especially in areas that are vast geographically, with poorly developed infrastructure, patients have difficulties accessing cataract surgical services. So models to address patients or people who live in such areas are really important so that they can access services. And this can include things like having mobile clinics, because in some of these vast areas, it may not be possible to establish stationary eye clinics that patients can access easily. So having models that probably use mobile eye clinics or planned outreaches and linking them to referrals, I think is really, really important. And also at the community level, we need to look at the myths and misconceptions or misinformation that goes on out there, because this is a key barrier, because patients then fear to come for services. So how do we ensure that we address this? And we can use strategies such as using champions, people who've had successful surgeries, helping us to advocate at the community level, or even opinion leaders at the community level who can help us translate our technical jargon into a language that communities can understand. Because sometimes when you talk, it's quite technical and it may not be understood. So it's really important that we use people that can pass the message across, and also targeting the decision makers. It could be a spouse, it could be a child who's financially supporting the parents, because sometimes you don't reach these people, and they're the ones who determine whether the people we are interested in are able to access services or not. Yeah, so from the health system side, I'd like to look at this from the primary healthcare level and then the secondary level where we have our eye units. So primary healthcare is really important, and integrating primary eye care into primary healthcare is really, really key, because primary level facilities is where our patients first get into contact with the health system. So when we embed primary eye care into our primary healthcare facilities, then we're able to reach these patients and ensure that they are referred early and without delay. And program data from different projects that have been implemented in Kenya have shown that 70 to 80% of eye conditions identified in communities do not require specialist services. They can be managed at the primary level. So managing these at the primary level means that we reduce unnecessary referral and unnecessary costs incurred by the patients. and also decongest our hospitals so that our staff can focus on the complex cases like cataract surgeries. So I think primary eye care, we're ensuring that this integration at the primary healthcare level is really, really key. And it also ensures, it serves as a triage point and a referral for patients who have cataracts to the higher level facilities. At the secondary level, it's important that we have efficient services and that our patients are getting a positive experience, because when they get a negative experience, then that drives the demand down. But when they have a positive experience, when they go back to their communities, then they speak positively and advocate for patients to come forward for surgery. So I know we've discussed about quality, but I think this is really, really key. And it's not just, we shouldn't just focus on the surgery itself, but the entire process, from when the patient interacts with the system, or even from when we are reaching them at the community level. I think we need to look at the entire process, not just the surgery in itself. And it's important that we audit ourselves. We audit the outcomes, but we also audit the other aspects of the health system. Yeah, so and just to conclude is that when we have satisfied clients, then they become our advocates. And our positive outcomes directly drive community demand. Yeah, thank you.
Thanks, Monicah. Fantastic points there. Lots of really rich, important points there. Just if I could ask a follow-on question, thinking about, particularly around the Kenyan context, what specific policy levers you have found to be helpful in shifting things?
Yeah, so some of the levers that I would like to speak about, number one, is the community level health promotion and early identification. And in Kenya, there's a lot of focus on primary healthcare. And we have what we call the primary care networks and the community health promoters, and we can use this basically to help us carry out health promotion at the community level. So that's one key lever, given that you already have that system in place, so we can just use that and integrate eye care into that. And we even have an eye care module in our community health promoters training manual. Then the other thing is integration of primary eye care into primary healthcare. I think this is really, really important. I've spoken about it. I don't think I need to explain further. Then health system strengthening. And this means that we need to ensure that our workforce have an enabling environment, number one, in terms of consumables, equipment, infrastructure, and also having a well-skilled workforce that is optimally used, because sometimes because of challenges of consumables and all that, then we find that we are not using our workforce optimally. And also where we need to upskill our workforce, then also that needs to be available so that we are giving quality services. Then we also need to look at sustainable financing mechanisms. And we have policies that reduce financial barriers for patients, such as social health insurance. And in Kenya, we have what we call social health insurance, basically. And what this does is that compensation of health facilities for things like cataract surgeries, for example, and especially for the public hospitals, was increased from compared to the previous insurance that we had. And this enables the facilities to be able to generate income. And we also have policies that allow ring fencing of funds within the hospitals, the funds generated within the hospital. So I think this is really important in ensuring that we have sustainable services, because we can generate our own income within the eye units and within the hospitals where those eye units are located. Then I think something that we really need to think about is about reaching the communities that have poor reach, our nomadic communities, the communities in the arid and the semi-arid areas, and the underserved populations. I think that is an area that you've not comprehensively covered. And I think it would be good to have a model that works for them, because we cannot have a one-size-fits-all, but we need to have it contextualized depending on the community. Thank you.
Monicah, thank you so much. That was fantastic. I'd like to turn to Katie now, if you want to unmute yourself, Katie. And I'd just be really interested to hear from you what you have found through the work of Keel Blindness and the other things you've been involved with over the years. What are the primary causes of difference in quality between countries that you have observed?
Well, thank you, Matthew, and thank you to all the presenters. Really, really important research and guidelines coming out today. So really appreciate being a part of this. I think when we look at quality, there are a number of different factors, obviously, but the main factors that I've seen throughout work in a number of different places really revolve around training as well as equipment. Certainly, these are exacerbated by prior to now the lack of a consistent minimum standard. But I do think that the key is really ensuring that all surgeons at whatever level really have the opportunity to train and then practice so that as they are delivering care, we all know that each cataract case is going to be different. It's going to have different complications and different unique circumstances. But we want to make sure that people really have sufficient training to be able to address what that care is needing, as well as liaise with others to ensure that both the pre-op care and the post-op care is what it needs to be. I think one of the other important pieces is, as I mentioned, making sure that there is the right kind of equipment involved in the process. You mentioned that ocular comorbidities was one of the leading causes of poor outcomes. And, in many ways, some of this comes down to, do we have equipment to do biometry so that people can identify some of these pieces in advance? Do we know what are some of these other comorbidities are to make sure that the proper training is at the bedside, and that we're prepared for knowing when to do the right surgery, how to do it, and what other additional post-op care might be needed around there. So for me, I guess the final thing I would say is that a factor more broadly in looking at our quality is our ability to have comprehensive data collection. So obviously, a lot of the data that we already saw earlier in the presentation is critical to be able to be measuring, any progress or even the current status. And we know that in many, many places, we don't have that kind of comprehensive data.
Great, thank you very much, Casey. Kind of building on some of those points that you've raised, are there any particular actions beyond the things that you touched on already that you have found, or programs have been involved with, found have really promoted that increased quality? Perhaps drawing on some of the stuff that's coming out of the WHO manual as well.
Sure. Well, I would start where I just finished off, which is I think what you get is what you measure, or what you measure is what you get. And so being able to accurately assess where we're seeing success, where we have opportunities for improvement is really critical to starting that improvement. I also think that now, having clear minimum standards is going to be extremely helpful in a number of different areas to be able to start looking at it and saying, are we putting some of the minimum best practices in place? And I want to be clear, I do think that it's important for us to recognize, quality of life was mentioned earlier. And so taking somebody from seeing light only to being able to count fingers is a significant improvement in life, even if it's not a 6/12. Obviously, I think we all want to continue to strive for that target. There's no doubt about that. But I do think we need to think about that in terms of the impact on the individual. But again, I think training, not just ensuring that someone has the basic training, but also building a system so that every surgeon, particularly those who maybe have less experience, having a system where they are, where they have the support of more experienced doctors to make sure that we're building that sort of that cycle of quality that we want is really important. I mentioned the equipment. I think the other piece that I would really emphasize is one of the other leading causes of poor outcomes was refractive error. And I think we see all too often that refractive error care and cataract services are pursued separately. And I think we all need to really be thinking about this from a patient-centered point of view and really bringing those together and making sure that we are partnering as NGOs to provide comprehensive care, which is in the end going to provide the best quality outcomes for each and every patient.
Super. Thank you very much, Casey. I'd like to turn to Jacqui now. Jacqui, how do you think we can use these and similar data to better understand inequality in terms of cataract surgical provision?
Thanks, Matthew, and congratulations to everyone on the presentations. So first, I guess I wanted to highlight a point that we make in the paper, which is that the lack of gender disparity at the global level that we've reported doesn't mean that we no longer have a gender inequity problem. So while it's really promising to see the smaller gender disparity than we're used to seeing in a lot of eye health outcomes, I just wanted to highlight that the data that we've presented are aggregated and modeled. So that means that there's still many parts of the world where gender disparity remains a significant problem. So I sort of encourage us all to think and draw on local data when we're planning gender responsive programs. And then I guess along similar lines, I think is sort of encouraging us all to expand the social axes along which we explore disparities, and that these will be different in different settings. And Monicah gave some really nice examples from Kenya of groups that we should be thinking about in terms of service access and quality. And I think the eye care indicator menu and other WHO tools give us some really useful service indicators that we can monitor to see whether or not we're moving in the right direction in terms of driving up ECSC. And I think Katie sort of pointed to that as well, the importance of expanding what we're thinking about. And I just thought I'd highlight the example of preoperative visual acuity, which can be a really nice proxy measure for thinking about access to services. And so here in Aotearoa, New Zealand, where I live, we know that our Māori, who are our Indigenous peoples, present for cataract surgery with much worse preoperative visual acuity than other New Zealanders. So we don't have survey data here in Aotearoa. So sort of monitoring preoperative visual acuity and knowing about this inequity means that we could prioritise efforts to improve access to services for Māori, and knowing that any improvement that we can make for access for Māori would mean that we are contributing to increasing our ECSC. And I guess the last point I wanted to mention, sort of the added benefit if we're going to expand the social axes that along which we're sort of monitoring service access and quality of services, is to understand, to think about intersectionality and sort of recognizing the potential for barriers to improve, to increase the more social axes along which a person experiences disadvantage. So, you know, an example is that not all women have the same lived experience. And so women with access to more resources are able to access services. And so if we're thinking about perhaps rurality and gender, or perhaps social support and marital status or socioeconomic status at the same time as gender, we'd get a much more nuanced picture of people's experience. And so maybe that's something to think about as well, and being able to target specific groups when we're planning services to drive up ECSC.
Great, thank you very much. Really important insights on that intersection of different axes and the need to really target groups that are being left behind, and the importance of disaggregating and really understanding what's happening in the population.
Absolutely.
Yeah. Stuart, may I turn to you now? And I just want to dig into some of the caveats that there might be around using CSR, cataract surgical rate, and ECSC, both for tracking progress and reporting.
Yeah, thank you. It's a very important question, Matthew. And I think it's, I think this leads on quite well from a few of the comments KT made and also Jacqui made before, is of course effective cataract surgery coverage, cataract surgery rate are very useful indicators at a country level to periodically track outcomes and impact of the work done at the country level. They're sort of the one point in time snapshot of access, and in the case of effective cataract surgery coverage, also quality of services. But as alluded to, a much more comprehensive set of indicators are needed to inform routine planning for cataract surgery services. And WHO really has recognised this need, and in 2021 and then subsequent in 2022 and 3 published an indicator menu, and then more of the first aggregate module with a more comprehensive set of indicators that can be integrated within routine health information system reporting. And these included indicators such as waiting time for cataract surgery, as Jacqui mentioned before, preoperative visual acuity, and also surgical outcomes. At the moment, we're looking to further operationalize that, and we have now a case-based indicator menu set that even includes additional indicators, dropout rates relating to cataract surgery, and those types of additional complication rates, those types of additional indicators. So really, we will be looking at the moment and working with a couple of countries to start to implement this module and move it forward. We recognise that, you know, strengthening the health information system around eye care, but in particular, there's a big opportunity around cataract care. It should be a priority for us moving forward. And for this to be successful, though, we must say that it's not an easy thing to do. It does require time, resources. It requires the different ministries coming together, different components of the ministries coming together, from the eye component to the health information system. Also the NGOs helping with convening and technical work around implementation as well. So it is a lot of work. It's not a quick fix, but I think certainly it is worth the endeavour.
Thank you. It's really exciting to see real momentum building now in this space. And yeah, I think what's coming through is the importance of data, not for data's sake, but to really shape and drive action, to track progress, but ultimately it's about moving it forward so that people really benefit. Thank you, Stuart. Can I turn to Andrew now? And I want us to kind of slightly change our focus now onto incentives. You know, what you think needs to change around the incentive structure to really solve the problem of cataract and surgery, moving it from situation we are today to something that's really sustainably moving forward for us as a global community.
Thanks, Matthew, and thanks to everyone who's online with us. So I'll answer it in two parts. One is kind of building on some of the comments already made around, you know, the importance of being able to do routine quality measurement. One thing that is covered in the paper, that quality has many dimensions that go beyond visual acuity. So one thing is being able to have a straightforward, reliable way to measure not just visual outcome after surgery, but also visual function, quality of life, satisfaction with the service, things that actually drive measures of, are people likely to uptake the service again for the second eye or recommend a colleague. And so that's, if you like, being able to measure the patient incentive to go again or recommend to another. From the supply side, from the hospital, I think often the elephant in the room that isn't discussed is we're chronically under-resourced in eye care. But one of the reasons is the incentive base as a surgeon or surgical team doesn't align with the impact that needs to be made. And that's because, broadly speaking, surgeons have to choose between either doing well or doing good, which means they can make a good income working in the cities, which is why you see the distribution of surgeons is primarily in the big cities, the metropolitan areas, where they can derive an income from those who can afford out-of-pocket payment. And those who are working in the more rural, serving the more vulnerable groups, are more attached to where there's external financial support. And I think unless we change the script on that, we're never going to accelerate the progress to the level we need to. So the question is, what can we do to unlock the financial shift that happens when someone's sight is restored in the individual or the household, in a way that means the provider of services is no longer choosing between an income, a reliable income, and serving those who are of a low income. And we're seeing potential models around that where there is an opportunity to shift that, particularly when there's a very strong functioning social health insurance mechanism that covers cataract. So for the high volume units who can treat patients at a level where they are generating a surplus for treating the lowest income people because of the reimbursements, that starts to create a really positive environment in terms of starting to reinvest resources in doing outreach. So I think there's a real role for philanthropic support to be catalytic rather than funding time-bound programs or projects. But it will require us to blend different financial models, really understanding the incentive is, it's not that surgeons don't want to support people. No, actually many people are driven to, but they equally have to make a choice, and you know, they have their own families to support and so on. So I think that's a problem we have to grapple with.
Great. Thank you very much, Andrew. I think, you know, the challenge of creating an incentive structure that is a win-win for everyone is so crucial. And I think it's something we haven't really attended to nearly enough. So thank you for raising that. Jacqui, can I come back to you again and talk a little bit about, ask you a bit about data? And I know you're doing quite a lot of thinking about using service data from cataract surgical services at the moment. And I just wondered what your observations might be around what are the biggest challenges, but also what are the opportunities for collecting high quality cataract service data, potentially at a national scale, kind of building on some of the things that Stuart mentioned as he spoke.
Thanks, Matthew. Yeah, and I think sort of absolutely building on comments already made, but yeah, a really exciting opportunity that I see is the potential sort of increased value placed on cataract data at the national level, given the WHA target and sort of the reporting requirements around that. And so I guess a key opportunity is that facilities do tend to collect a lot of service-based data for cataract. And it's really sort of that can be used for us to know whether or not we're moving in the right direction. And I think Stuart sort of pointed to this. Sort of a key challenge is the quality of that data, and I think sort of establishing the processes to strengthen the health information system, and then including sort of the compilation of data collected at that facility level, and it makes its way up through administrative levels up to the national level. And yeah, as you mentioned, Matthew, we're currently working with the Fred Hollows Foundation on a really exciting project with partners in China and Nepal, and I think some of them are on the call today, which is great. And we're trying to develop methods where we might be able to estimate ECSC drawing on routinely collected data. And I guess through this process, it's been really heartening to see stakeholders recognise that value in the data that's being collected at the facility level. And we're starting to strengthen, the data and supporting processes. So I'm sort of really hopeful that we're sort of pulling together a methodology that might really help strengthen that health information system, but then give us the ability to track ECSC in between population-based surveys.
Thank you, Jacqui. We've just got a few moments left. I just want to quickly come back to Stuart and possibly Andrew to ask a bit about some of the challenges, but also the opportunities in relation to the eye health workforce. And then if we've got time, we've got a couple of questions in the chat I'd like to try and...
Thanks, Matthew. I'll be very quick. And I think I'll be very quick because I think Monicah gave a very good overview of workforce strengthening at a country level. So just to emphasize a few of Monicah's points, I think, of course, it is one of the biggest bottlenecks to scaling up access to cataract surgery services. But I think we need to think about it in a way that it doesn't just mean increasing the number of surgeons. That's, of course, needed, no doubt. That is, of course, needed, but it does, of course, take time as well. Sort of more lower hanging fruits are, of course, addressing some of the inefficiencies in the existing workforce, which were alluded to before. And I don't say inefficiencies in a negative way. I say it in a way that many surgeons are tied up with non-surgical tasks that could potentially be alleviated at lower levels of care. And this is only possible going back to Monicah's point. We need to really fundamentally build a strong eye care within primary healthcare to be able to for this to happen and to improve these efficiencies. So I'll leave it there, and Andrew may have something to add.
Yeah, very, very briefly, I'll just build on that, although I agree we need more surgeons, I think first we need more surgeries, because what we see in the data is usually 20% of the surgical workforce is doing often close to 80% of the surgical throughput. So there's a few, if you like, outlier high volume surgeons, and it's not necessarily because others don't want to do the work, but the ecosystem and all the things that have been described eloquently by Monicah and others isn't in place. So actually, until we solve those problems, the capability to make becoming an ophthalmologist or part of the ophthalmic workforce an attractive profession is also limited, because until it's optimized, until there's the capability to work in partnership with other people, you don't have a community of other practitioners, and so it becomes quite a lonely role, particularly if you're trying to work in the underserved areas. So I think we've got to address that as a critical near-term thing, optimizing the services to do more surgery with a view longer term, bringing in more surgeons into the profession.
Thank you, Andrew. We're at the top of the hour, so it's the end of our time together. I just wanted to say thank you very much to all of you online for taking the time to join us. Thank you very much to the panel for the talks and the discussion we've just had. Lots of food for thought. Just want to mention that we will be sending out to all those who registered for this webinar links to the recording, to the papers, and we will endeavour to respond to the questions in the chat and the Q&A box as a circular of the frequently asked questions. So hopefully, thank you very much for proposing those questions, and we will get back with a sort of circular response for that. Just to say, we're going to probably have some more such webinars in the coming year. So do look out for the invitations and links to those. And thank you very much again for joining us. Good evening.
Thanks, everybody.
Thank you.